Professor Togher is from the University of Sydney. She's been a speech pathologist, worked in the area of communication disorders after brain injury for over 25 years. She's got a long bio, but I'm going to give her more time to speak, and her paper title is Telehealth Models in Brain Injury. Thanks, Leanne.
Thank you. And thank you to all of you for coming, and thanks to Maria Crotty for this wonderful invitation to speak to you today. E-health really remains a relatively new phenomenon, I think, in the field of TBI rehabilitation, although it's clearly growing in popularity in both private and publicly funded, private and publicly funded clinicians. What I'd like to do today is present some early work that we're doing in this area, which is being led by two of my students, Rachel Redake and Emily Guo. Emily's in Singapore, and what we're wanting to do is really, we're going back a few steps, I suppose, from the last two speakers, in just looking at the evidence that supports these approaches and what's been done in the past. So our first question was whether the studies had been conducted, particularly looking at telehealth with families of people with traumatic brain injury. So Rachel conducted a systematic review to answer this question, and what she found was that there had been 16 studies done, 7 RCTs, 4 non-RCTs and 5 case series. So it's still very much in the infancy, I think, in terms of systematically investigating these telehealth interventions to support families. What did we find? There was definitely evidence for effectiveness of telehealth interventions. All but one of the studies reported some kind of positive outcomes for the intervention being investigated. There were significant outcomes both for the person with TBI, for their functioning, and also for the family members, particularly in terms of measures of psychological well-being, their feelings of support, their feelings of relief of burden. And it also became clear that an interactive skills-based program, which was just so beautifully described by the previous two speakers, was much more effective than just giving people information. So we concluded that telehealth may well be a feasible and effective way to work with communication partners of people with TBI, and that's a particular area of interest of mine, is obviously training the person with brain injury, but working very interactively with families and giving them skills and strategies. So once the systematic review was done, our next question related to the feasibility, efficiency and reliability of conducting speech pathology assessments using video conferencing facilities such as Skype. And this has led to an ISCAR-funded study which is investigating these exact questions. So our telehealth project called TBI Connect was born. We've previously found that working with people with TBI together with their families leads to better conversations and overall improved social communication skills. The intervention from this research has been developed into a manual that we called TBI Express, and that was an NHMRC-funded clinical trial. But many families, as we've heard, are not able to access this type of training or other effective interventions, being separated from a specialist brain injury service by distance. The competing schedules of family members can make it impossible to attend an in-person session. Additionally, physical problems and cognitive problems that are associated with TBI can inhibit a person being able to come to appointments. So what we were really wanting to do in this study was look at the potential of using video conferencing to overcome these barriers. Before we actually trial using Skype for the treatment though, we wanted to make sure that we were answering some of the more fundamental questions, such as would it be feasible and efficient to meet with the families over Skype? Would we be able to identify communication problems over Skype? Would families be happy with this as a treatment model? So we've undertaken an assessment study first, which is our preliminary step before we move on to the further intervention studies. And this work is still in progress, I should say. To date, we've had 14 participants with TBI and their family members recruited to participate in this study. from 2 metropolitan brain injury units and 2 rural units in Sydney. Sorry, just outside of Sydney. All the participants have completed the same communication assessment protocol twice. One session has occurred at their home in person, and then 1 to 2 weeks later they would receive one session over Skype. We have been sure to randomly allocate whether someone gets the Skype or the in-person session first. Our participant criteria, because I've got not a lot of time, I'll just summarise by saying that we were looking for people with moderate to severe TBI at least 6 months post-injury, who had obviously a social communication problem, and who had a communication partner who they were able to interact with. There were a number of other criteria there which I won't go through today. And what we've tried to do is recruit people across a range of severity, but nonetheless we have a moderate to severe group, chronic group, and the demographics are there for you to have a look at, but it's mean age of 42 years and predominantly male, as is the common occurrence after TBI. The partners were mostly partners, so wives and husbands, parents. We had 2 other family members involved, and we also included friends. So we're investigating the reliability of a number of different commonly used outcome measures by speech pathologists that involve looking at conversations and rating how much the person participates in a conversation, how well the communication partner supports that interaction. And we also have a number of rating scales where the person is rating their own communication skills. And I'm going to talk about one of those today, the Latrobe Communication Questionnaire. But these are the outcome measures for our clinical trial. Okay. So the Latrobe Communication Questionnaire is a 30-item questionnaire where you interview the person with brain injury, and there is a self-report form, and then separately you interview the family member, and it's to get an idea of how they perceive their communications going. So you ask them questions like, when talking to others, do you leave out important details? And they answer that on a 4-point scale from never, I never do that, through to usually or always. You can sum up the scores, and if someone gets 120, they're perceiving big problems. If they've got a score of 30, they're not thinking they've got many problems. So why do we? So for the in-person session, the speech pathologist completed the questionnaire with the family at home. When we did the Skype session, the speech pathologist was in a quiet office. They were writing down the participants' responses. We had mailed a paper copy of the questionnaire in advance so that the family had that to refer to. We thought we should check the reliability of questionnaires because we wondered whether doing these tasks over Skype represented a different cognitive task, and whether it also, particularly because we're interested in communication, whether it was a different social activity to talk to a head on a computer rather than in the same room. We were particularly interested in looking at whether the interaction was different in terms of willingness to request clarification, whether there was they were disclosing as much information, and the length of their answers. So in answer to our questions, was it possible to use Skype for assessment sessions? Yes, it was. 100% of them did happen. However, 1/3 of these did have Skype connection problems, and for anyone who's used Skype, I'm sure you've experienced that, so phone did have to be used as a backup in 36% of the cases. In terms of participant ratings, we asked them to rate their satisfaction with this mode of service delivery on a 5-point scale, and these percentages show the participants who chose one of the 2 top categories. The technical issues did impact on people's satisfaction with the service delivery. Most rating, and it affected the ratings of the family members more than the people with brain injury. So only 62% of family members were more than satisfied or very satisfied with this. We also wanted to know whether it took the same amount of time to do this assessment using both modalities, and we counted the number of seconds, and indeed there was no significant difference. So the same amount of interaction happened, the same flow of conversation, the same amount of clarifications, questions, etc. Importantly, these should be reliable, these measures, and I think over the coming years we're going to see many more reliability studies being reported to make sure that we are getting a true record during a Skype assessment. What we found was that the correlation between the participants' scores during the in-person interview and the Skype interview were in the very good range, and luckily we had work from Jacinta Douglas, who had previously reported test-retest reliability, and happily our correlations were similar to hers. So we're confident that it was a reliable assessment. So using Skype is generally feasible, although not perfect. It was as efficient as an in-person interview. It was reliable compared to the in-person administration. We also invited our participants, our TBI participants and their families, to tell us how would they like Skype being used, because I think we heard this morning how important it is for our consumers to be directing and guiding what they'd be comfortable with. They had a lot to tell us, really. So reducing travel was probably one of the biggest ones, and we've heard that this afternoon as a recurrent theme. Getting access to experts, a way for helping families feel less fearful and less isolated. They thought it would provide a way to provide therapy differently. Transitioning from very intensive treatment to less intensive treatment might be smoothed over by using Skype. One of the things they said they didn't think, but they obviously didn't hear Trevor Russell's talk this morning, was that there could be a problem with physical procedures, therapies that include physical resources, and they also thought there might be an issue with group discussion sessions. But on the positive side, they thought it would be useful for structured sessions, therapy focused on what they called mental functions, repetitive drills, making the brain injury staff more accessible to them. They thought it would be helpful for them and the clinician to have this type of interaction as a screening tool before having a home visit, having someone come out to their home. We also had people say the opposite, that they thought it would be good to have a face-to-face appointment with the clinician first before they embarked on a Skype treatment program. Supporting other family members who may not ever get into the hospital, that this could provide an avenue for them to be interviewed, and particularly when they're in an inpatient setting, to help them maintain contact with other family and friends. I thought Skype would be useful for that. For family members to meet with other families, for the person with brain injury to meet their peers with people with brain injury, and also as a therapeutic way of helping the person with brain injury with their own organisation. So e-health clearly, I think at the moment, is underutilised. There was a report by the Department of Health and Ageing, Federal Department of Health and Ageing in 2011 on e-health, and it found 13% of allied health practitioners were using telehealth. So I'd call that underutilised, I think. We've got a long way to go. But I would imagine even in 2 years that's changed. So I think the other thing is we're in a rapid period of transition with this. I think it is important, before we all jump on the bandwagon, to ensure that what we're doing is efficient, reliable and as effective as, or if not more effective than face-to-face clinical encounters. From a speech pathology perspective, we have additional challenges associated with working with people who cannot speak and assessing people who can't speak or have limited communication because of aphasia. It was lovely having that example of Brian in the last presentation to explicate that. But we're also trying to adapt aphasia assessments to make them more accessible using remote tablet technology, and my student Emily Guo is doing that. Particularly providing, which Claire mentioned beautifully with a number of different apps, trying to provide ways for supported communication and for the person to be able to use gesture and drawing and other ways of getting their message across. Emily has worked with an engineer in Singapore, and this is a low-cost iPad program that she's prototyping at the moment, but it's called Access to Aphasia. And this is the screen. Oh no, that's not going to work. How do I? There we go. So this is the screen, and this is actually the test form. This is the assessment of living with aphasia. It's an aphasia-friendly, standardised assessment that you use to interview the person with aphasia who can't speak, and gives them options of responding in a meaningful way. So the question here is, how would you rate your aphasia and your communication with regards to your talking? And then they have a 9-point scale here, but it's got someone with their thumb down, someone with their thumb up. So the person with aphasia can literally just touch the iPad and that's their response if that's all they've got. They've obviously got the video of the clinician there, and then this is their interactive whiteboard space that if they want to try and draw something, they can enhance what they're doing. And this is what the speech pathologist sees on the other side. So once again, they're going to get the response here on there, which goes immediately into an Excel spreadsheet. And then they can either confirm that they can confirm that that's the score with the person. They can also be drawing if they need to, which we often do. They'll have a video, and then they've obviously got the scale. So we're trying to adapt quite a lot of assessments so that we can get this interaction with patients by distance. I think there is the potential definitely for eHealth to facilitate better outcomes for people with brain injury and their families because of this potential for improved access, increased opportunity to practice treatment targets, and also to network socially. I think that can't be underestimated either, because a lot of the people that I certainly deal with have lost their friends and they are socially isolated. We are planning to continue with our clinical trial early next year to look at using TBI Express online, our TBI Connect. I think our previous speakers have mentioned this morning about the uptake of eHealth, and I think we have got a long way to go, but it's going to rely really on the perceived needs of our clients, as well as what the eHealth report from the Department of Health and Ageing talked about. They talked about infrastructural, aptitudinal and attitudinal readiness by practitioners, i.e. us. So I think the AFRM are definitely to be congratulated for providing a wonderful forum today to discuss these issues, and I thank you for your attention. Thank you.